So these 5 Ps, you do need to know these. So make yourself some, flashcards or something, and just learn what these are. Okay. So the 5 Ps of labor and birth include, and we're going to talk about these in detail, but just as an overview first, the passenger. Passenger is, of course, the baby, right? So it's talking about essentially the position of the baby, for the most part. Talking about the presentation, which we'll define in a little while, lie, attitude, and general position. And then the placenta can be included in that because it's connected to the passenger. Okay. And then the passageway, which is the way the baby is coming, right? So that's talking about the pelvis, the subpubic angle and arch, and the vagina. And then talking about the powers of pregnancy, they include primary and secondary powers. So this is like the force, right, behind labor. The force is the contractions, and then the manual force, which is the pushing, right? Primary power is contractions because it's voluntary, basically. I mean, involuntary. It's something your body does on its own, whether you help it out or not, right? And then the secondary power is something that is dependent on our efforts, and that's the pushing, right? The 4th P is the position of the mother. This is important because of how it affects the passageway, okay? And then the psychologic response. How is she coping with the labor, basically, okay? Some Ps that they might try to throw you off on would be like pain. I'm trying to think of some other ones, and I can't right now, but they'll throw extra P words in there, to try to throw you off. So just be familiar with those. Okay. So first we're talking about passenger, and underneath that, presentation. So when we're talking about presentation, we're asking what is the presenting part? Which part of the body is coming through the outlet first, coming out first, okay? So this is either cephalic or breech usually, or transverse, but we'll talk about those. First, we're talking about cephalic. That's, of course, cephalic is a head. When the baby's presenting head first, it's a cephalic presentation, but it sometimes can, there's a variation of this, right? So vertex is the normal crown presentation. Occiput is the term for this the crown of the head, okay? The brow presentation is when the head is extended too far and the brow is presenting. This creates a much, much larger circumference. And most of the time, the baby cannot deliver with especially a face presentation. A brow presentation is also a lot harder. So if you can imagine the baby delivering from the occiput, from a standard vertex presentation, the circumference here is tiny. If any of you have ever, if you have kids or even like nieces and nephews or cousins, or you babysat or something, and ever tried to pull a shirt on their head, you might know that it is much, much easier if you put it on this part of their head first, on the crown, because that's the smallest circumference, and it just kind of slides on, and then they can pull, their chin down that way. But if they try, like if a kid's trying to put their shirt on and they try like straight on like this, or especially like from the front of their head, it's like almost impossible to get that shirt on there, unless it's a wide neck, But same idea with the space that you have available in the pelvis. Okay, so the vertex occiput presentation is the most favorable for birth. And any of these other ones create such a larger diameter for the baby to try to pass through that it's sometimes not possible. Okay. So ideally, when we check the position of the baby, the presentation of the baby, we're feeling for this fontanelle right here. We want to feel the posterior fontanelle and be able to feel up to the anterior fontanelle so we can get an idea of how the baby is presenting. Okay. Then we have breech presentation. Breech is anything butt first or feet first. Okay, so there are different types of breech as well. We've got frank breech, which if you've ever seen a newborn after a frank breech presentation, which oftentimes is, in this day and age, breech is often C-section. Like it's safer to deliver by C-section. So we don't see a lot of like actual breech deliveries. And especially these are not possible. Sometimes they can get the feet out. But anyway, if you see a baby after they're born, when they've been frank breech in utero, their little feet go up by their head like this, even when they're out of the uterus. Like you put them on the table to do their assessment or whatever, and they just put their legs straight up by their face. It's pretty amazing how flexible they are. But that's frank breech. Complete breech is like the normal fetal position, but just butt first. And then footling, of course, is feet are coming out. Okay. There's also a shoulder presentation. If the baby is transverse or oblique and we check and we're feeling a shoulder, that's obviously shoulder presentation. And that has to do with the position of the baby, the lie of the baby, which we'll talk about in a minute. Okay. We'll talk about it now. So the lie is just a term for the direction that the baby is lying or kind of facing in utero. So this is always either longitudinal, transverse, or oblique. So at like another angle. Okay. Longitudinal is what we want, and that's the way they fit easiest. So that's the way most babies are in. Their lie is longitudinal most of the time, either vertex or breech. But sometimes the baby is transverse, like we just talked about this way, and then that might be the shoulder presentation. And sometimes they are oblique, which is just anything in between those two. They're just off a little bit. Okay, and then the fetal attitude is talking about the flexion of the head and neck and the body. So this, again, would have to circle back around again to the brow and the face presentation. A lot of times it's the maternal anatomy that affects the way the baby can fit and whether they're flexed or extended. But universal flexion is that classic kind of fetal position. And then, of course, flexion is a preferred position because, again, if you can imagine, kind of delivering through here, and then they're able to, as they deliver, they're able to extend their neck to kind of come around the curve of the pubic bone. If they're already extended, there's nowhere, it's so much harder to deliver because there's nowhere for them to move and be flexible to make the turns. Okay. Let's see. We already mentioned these things here. Okay. And then fetal position. So one of the other items that you might see, like especially in clinicals, if you look at a delivery summary or whatever, the doctor or midwife might say the baby delivered vertex, ROA, over an intact perineum or something to that effect. So they'll use these acronyms. Now, OA is the best position. OA means occiput anterior, which means to the mom's belly side, basically. Posterior would mean to the mom's spine. So if the occiput is closer to the mom's spine, then that would be OP, occiput posterior. And that means the baby is what laymen call sunny side up. Okay, that means that the baby's going to come out, once the baby rotates, come out face up, where the baby's back is to the mom's back. And that's very hard, again, to just make some of those turns. Because if the baby's face up, they're having to try to come up. It's just harder to make those turns around the pubic bone, okay, and through the pelvis. So OA is the preferred position. OP is sunny side up, occiput posterior. It's back to the mom's back, and that's harder to deliver. And then the R's and L's are right to left, right? So if the baby is ROA, then the baby's back is toward the mom's right side. If you can imagine, she's laying on her back here. This is her front. The baby's laying on her right side. If the baby's LOA, then the baby's on her left side. All right. And then transverse is just in between, right? It's not anterior, not posterior, but transverse. So the baby's back is facing like exactly to her right side because it's at a 90-degree angle. Whereas this one's a little more anterior. It's kind of like a 45-degree angle to the mom's belly and side. Okay. Does that make sense to everybody? Does anybody have questions about that? Yeah, go ahead. Oh, you're muted. Hold on. For me. I can't unmute you, but I can prompt it. There we go. Uh-oh, still not working. I don't know. Yeah, I don't know why it's not working. Yeah, if you want to just try to type it for now. Okay. I'll go ahead to the next. Oh, I see. So ROA is face down. Yes. Once the baby delivers, the baby will be face down so that as they deliver, you see the crown and kind of the back of their head first and rotate out. So face down. Good. All right. Then we're talking about effacement and dilation. So I need to add a slide on here probably. Let me click one more slide. Okay. Yeah. So another thing you'll see in either report or various stages of the documentation during labor, you're going to have a three number kind of figure there. I have this dry erase board, but I'm not sure my kids. Oh no, here's the marker. Somebody might already know this, so I'll just throw it out there and somebody can answer and then I'll explain it. So I'm going to make up a cervical exam. Okay. So anybody? Is this backwards for y'all? Is it flipped or can you see it? Why are you so quiet?
I think it's like 2 centimeters dilated, 50% effaced. I'm not sure what the -3 is.
Good. Okay. Anybody know what the -3 is called? And I'll explain what it all means. But all right, -3 is the station of the baby. Okay, so let's talk about all that. So the first number 2 is 2 centimeters, and that is talking about dilation. Dilation, if you can imagine, a cervix is like this, and normally it is. It's like it's just almost like a button. Feel where there's like a ridge and then kind of a dimple in the middle. Okay, this would be closed And if a mom came in for triage, she thought she was in labor and we checked her and her cervix was like this, we'd call that closed and thick and probably high, which refers to the station, which means the baby's high up in the pelvis. Okay. So dilation is referring to how open the pelvis, the cervix is. Okay. And effacement is referring to how thick it is. So it's like if I took some fingers away and now the cervix is only this thick, then that is a certain percentage effaced. So let's say the cervix is normally this thick. It's not. This is probably almost double what it normally is, but just as a visual. The cervix is now this thick, that would be 25% effaced. Okay. So the closer you get to 0, the smaller it is. So the closer you get to 100%, the thinner the cervix is. Let me make sure I say that right. Okay. So once it's now this thick, then that's 50%. And once it's this thick, that's 75%. Okay. And then when it gets completely thin, it might still not be dilated. You can be, 4 centimeters and 100% effaced. And what we call that is tissue paper thin. So you can actually find the edge and feel the cervix all the way around. And it's still only about 4 centimeters, but it's tissue paper thin. It's 100% effaced. Okay. So let me go back to this and show you. So again, dilation is how open the cervix is. So how big is opening now in the cervix? So if we're looking at just dilation on this one, here it's closed or maybe fingertip. Here it looks still about fingertip probably. And then here maybe about 1 centimeter. And here maybe 3 to 4. Well, here it's saying 10 centimeters. I'm just looking at the, I was looking at I was eyeballing the space there, but this is the vaginal vault. So it's saying it's 100%, 10 centimeters now. And here it's saying 3 centimeters. But the way we measure that is by our fingers when we're getting, when we're doing a cervical check. So 1 finger for most people is about 1 centimeter. And then 2 fingers stacked on top is 2 centimeters. 2 fingers side by side is 3 centimeters. And then you start doing the spacing. And that takes skill and time to figure that out. But so dilation is the measurement of how open it is. Go ahead, Ivana.
So besides, so like I say, a mom comes and she's triaged and she's 0 centimeters dilated. Besides not having sufficient amniotic fluid, is there any other reason that you guys would keep her?
Oh yeah, lots of reasons.
Or like maybe like vitals and stuff like that too?
Sure, yeah, and especially like the baby's heart rate. So basically the baby's vitals, as far as we can assess them, outside, of the baby being delivered. So in utero, we look at the baby's heart rate as the biggest kind of vital sign and important thing for the baby's health. And you'll see when you watch the fetal monitoring video, that'll explain that in a lot more detail. If we have time, we'll touch on it today too. But yeah, there's lots and lots of reasons, infection, blood pressure, which we'll talk about, all the different types of complications too as we go through the semester. But there's definitely a lot of reasons that she might need to stay even if she's not in labor yet. So good question. Okay, so that's dilation. And then effacement, like we mentioned, is the shortening and thinning of the cervix. So it's sometimes referred to as the cervix being taken in or obliterated. The cervix just dissolves into kind of the sides of the uterus as it's allowing the baby to come down through the pelvis. So again, this would be like 0%, 50%, 100% is, I don't like this picture because this would be like, if it's 100%, it's literally tissue paper thin. So that picture isn't the best, but you get the idea with that. This is a kind of a cool video to illustrate that too. If I like the balloon in a ping pong ball in a balloon illustration there that you can look at too if you want. Okay, and then the third number that in my example was -3 is talking about station. Station is just what is the position in the pelvis? We measure from the ischial spines, which is actually kind of hard to see in this picture. But if you look at an image of the pelvis from the front, you can see little I don't know, protrusions that are like a little bit pointy, and that would be 0 station. Okay. And then the more plus you get, the closer the baby is to delivery. Okay. So if the baby is at 10 centimeters, 100% +2, then she's ready to push. Okay. Because the baby's pretty close to coming out of the outlet there. +4 is like crowning. So like the baby's already, partway through the vaginal opening. But then the minus, so like our baby in our example, -3 is still really high. Like that baby's hardly even engaged yet, which is the term we use for like in the pelvis, like drop down into the pelvis. And if we're -4, -5, then that baby's probably still ballotable, which I think I mentioned last week, but ballotable is like, the baby might kind of settle down onto the cervix, but if I can push the baby's head up off of it, and then it'll like float up and then kind of bounce back down on the cervix or on my fingers, and that baby's ballotable. It's not engaged at all, and it's -4, -5. Okay. Any questions about differentiating those? Okay. So let's do this. I'll put up a poll here. After doing Leopold's maneuvers, the nurse determines that the fetus is in the ROP position. To best auscultate the fetal heart tones, Doppler is placed. I'm going to put it, you may not know this, and that's okay. So baby is ROP. Would you put the Doppler for the fetal heart tones? A, above the umbilicus at the midline. B, above the umbilicus on the left side. C, below the umbilicus on the right side. D, below the umbilicus near the left groin. I need about 5 more people to respond here. All right. Good. We're going to go with that. Okay. So this was kind of a guess, and as you might expect, the answers are kind of varied. But the correct answer is what 55% of you got is C, below the umbilicus on the right side. So the reason for that is the baby is head down, which means its heart is over here. If you're hearing heart tones above the umbilicus, then you might suspect that the baby's breech. Okay. And then we're going to hear, even though the baby is OP, so that's the baby's back is to the mom's back. We're going to always be able to hear the heart tones the best over the baby's back. So we'd be more likely to hear it best on the mom's right side, the side that the baby's back is on. We'd be able to get heart tones even easier if this baby was ROA. So the back was kind of facing out toward us to the mom's belly. But this is still going to be the best chance to start to try to get heart tones there. Okay. All right. All right. You also have 4 basic pelvis types. So now we're starting to talk about the passageway. Gynecoid is the most favorable for birth. It's got the biggest space for the baby to come through. Okay. These other types are more difficult, and the android is the hardest. Android is the most similar to the male pelvis, and it's a heart shape, and you can see these are the ischial spines, by the way. You can sort of see them from above here, but you can see it would be hard for a big round object to go through this space. The only space it really has is like this much, right? So then platypoloid is long, like an oval this way, and anthropoid is an oval front to back, if that makes sense. Okay. That's just something you have to memorize, basically. All right, and then now getting into the powers. We talked about this briefly already, but the primary powers are contractions, secondary powers are pushing, bearing down. All right, so the power, that's getting the baby out, contractions and pushing. All right, so now we'll talk about the process of labor. Signs, let's see, can someone still deliver naturally with a heart-shaped pelvis? The question is maybe, the answer is maybe. So it's definitely more difficult. She'd be more likely to have what we call CPD, which is cephalopelvic disproportion. Basically, the head, cephalo, isn't fitting in the pelvis, cephalopelvic disproportion. And it's literally different for every person and every baby, right? So it depends on the size of the baby and the size of the mom's pelvis. And there's really no way to know that a lot of times before labor. Sometimes a doctor or midwife can guess and try to measure and get a good idea, and sometimes even recommend a C-section if her pelvis isn't favorable, but it still doesn't mean, like, she could still try. For as long as her baby's tolerating labor, she could try and then maybe go to C-section if she has to later. So you just never know. But yes, it's possible. So signs preceding labor. So these are the things that we think of when a mom's like 38, 39 weeks along, and she's like, I know it's coming soon. And these are the things that are happening to me. Lightning, we talked about this a week or 2 ago, the difference between lightning and quickening, right? That's easy to get them confused. But lightning is dropping. It's making her breathing efforts lighter because there's more room by her lungs. Okay. So the baby's dropping into the pelvis. She might notice Braxton Hicks contractions strengthening. She might not. I never noticed any, really. So some people feel them strong and for a long time leading up to, and that's why they're think they're in labor and go in to see if they're in labor many times. But some people don't really feel them. Whether they feel them or not, they're still happening. They're still like tightening happening there, but there might not be pain with it. Those are those practice contractions, right? She's going to have an increase in vaginal mucus. Her cervix is going to start softening. She'll also get a surge of energy. We call that nesting a lot of times, right? And then bloody show is what's happening when she's actually starting to go into labor. So bloody show is just a combination of that increased vaginal mucus, cervical mucus too, mixed with a little bit of blood that is occurring because the cervix is starting to have changes, and the cervix is full of lots of little blood vessels. So as it starts opening or thinning, sometimes these blood vessels will burst, and so you get bloody show. So it's just like a lot of blood tinged mucus, basically, and that's a good sign that she is going into labor at that point. And then possibly rupture of membranes. So SROM is the term for that. That's spontaneous rupture of membranes. Anybody have any? Somebody tell me something you've seen on TV when somebody's water breaks. What happens? What does it look like, and how do people react? What happens after?
Like a
Maybe.
big splash.
Okay, yeah, big splash, a big gush.
One time when I went to go pick up a patient to go to an ultrasound, and they were doing a check for the dilation, and as soon as she took the hand out, whoa, it happened. But the
Yeah.
only crazy thing that it didn't freak me out, but I was like, I felt like nervous for her because the nurse said like, oh, mommy, we got poop there. So I guess like there was like poop mixed with with that. So I don't know what ended up happening, but she couldn't go down for an ultrasound period. But
yeah, so she meant that there's meconium in the fluid that the baby pooped in utero, and we're going to be talking about that too. But that's that is a concerning sign. That's something that
means like the baby's like stressed, right?
Yeah, the baby was stressed at some point in utero, and so it had a bowel movement in there. And then it's the baby's, remember we talked about last week, the baby's like drinking this fluid and breathing it in and out of its lungs. So it's got then poop mixed in with the fluid that it's getting in and out of its lungs, and it can cause respiratory distress after delivery. So it's something that makes us watch very closely, both the baby during labor and after delivery too, when that happens. Yeah, good. What else? Like in the movies, yes, usually they're like, my water's broken, and then they're starting to they're like, my water broke, and then they're like, oh, you know, like immediately, right? Like water breaks and the pain starts. That's not real life. Okay, so labor and your water breaking don't necessarily go hand in hand. So your water can break, and your body's not ready for labor yet. So you're not going into labor. If you're not educated about it, you might not know that you need to go into the hospital when you are leaking, whether or not you're contracting yet. You need to go. So because anybody know why? So your water breaks, you're not contracting yet. Why do you need to go ahead to the hospital?
I have kind of a side question on that. So, since you're saying that once they start leaking and their water breaks, they have to go, what about in the instances of women who go into labor, but their water never breaks?
Yeah, that's a good question on the flip side of that. So I'll talk about that too in just a second. But why do you think we're going to? Yes. So as soon as her water breaks, it's an open pathway to all of the flora and fauna that might be living in the vaginal area, and she's at risk for infection at that point. We would like the baby to deliver within 18 hours after her water breaks, 24 at like the most. By 18 hours, we're starting antibiotics. 24 hours, we're like, if the baby's not delivered, she's not in labor yet, we're going to be thinking about going ahead to C-section. It can go longer than that if like she's in labor and she's really close to delivery, but if not, then we want her, we need to do something about it by that point. So it does happen sometimes that a mom will be like, yeah, I think my water broke like 3 days ago, but I never went into labor. So, I'm just coming in now to see, or they wait until their doctor at their appointment or something. And we're always like, oh no. So anyway, we would start her on antibiotics. She's at risk for infection. The baby's at risk for infection at that point. But yeah, so labor doesn't always start right away, but sometimes, and more often, actually, it's really more common for your water not to break and for you to go into labor. And then sometimes it breaks on its own during labor. Sometimes it doesn't. A lot of times the doctor or midwife will break your water for you. So let's see, give me just 1 second here. So it's possible to deliver your baby and your water not be broken at all. There's a word for that, and I can't remember it off the top of my head, but you can have a delivery where the bag of water is still intact. So the baby's like, you can see the baby, it's like kind of just rolling around still in the sac there after delivery. It's pretty amazing. But it's not mandatory that your water breaks before. And in fact, because you're losing that cushion around the baby, it's usually, especially if you're not choosing to get an epidural, you're choosing to have a natural labor and delivery. Thank you, in-call birth. Y'all knew it. Or maybe you looked it up. Either way, thank you. So it's the contractions are more painful after your water breaks because you're kind of losing that extra cushion. It can also, it's usually not a problem, but sometimes the baby's heart rate, you'll notice a difference in the baby's heart rate because it's losing that cushion for the umbilical cord too during a contraction, that you might notice changes in the heart rate that once you learn about fetal monitoring, when you watch the lecture on that, it will make more sense to you. Okay. Let's see, there might be a little more. Okay, so about the fluid, yeah. So when somebody's water breaks, the questions that are important for us to ask them, we can use the acronym COAT, C-O-A-T, to remember what we need to know. So we need to know the color. Normally, we want it to be clear. Sometimes it can have flecks of white in it, the baby's vernix. I don't know if we've talked about vernix, but vernix is like the cheesy coating on the baby that protects the baby's skin in utero. it's kind of like having lotion. It's like a thick lotion on the baby's skin to prevent, if you know, we've all been in the pool or the hot tub too long, or you're in the bath or something, and then we get all pruny, you know, that kind of helps prevent the baby's skin from just getting too waterlogged, if you will. Once that starts wearing off, the older the baby is in utero, so like when you start to get closer to 40 weeks, 41 weeks, the vernix is like almost completely worn off, and the baby's skin will come out very peely because of that. So, so we talked about meconium. Meconium fluid is going to be green. So meconium in a baby, some of you may or may not know, their first poop, it's that tar looking black, thick poop. Okay. So to us, it looks black, but it's actually like a very dark green. It's kind of like if you've ever used food coloring, like a green food coloring, it looks super dark and black. And then when you start mixing it, you can see that it's actually green. If I'm talking about the gel, I don't know if y'all have used that before, but anyway, meconium is kind of the same idea. It's very black looking when they poop it into a diaper, but when they poop into fluid, it dilutes and you can see that it's green. So it's sometimes a thin meconium and sometimes a thick meconium that looks more like pea soup. We'll talk about this more later, but green stained is concerning. It means the baby's pooped, and that's meconium. Okay. There should not be any smell to this fluid. If there is a foul odor, then it could indicate infection, and we need to follow up on that. And we want to know the amount. So you can have a trickle. So it's not always just like what's in the movies where they have a huge gush. Some moms are just like, I don't know, but I'm constantly wet. Like I'm having to put a pad on because I'm so wet. I think I'm peeing on myself and I just don't know. But that can actually be their water broken. So a lot of times we'll have these moms put a pad on and walk. And if they leak with every step, especially if they've just used the bathroom and they're still leaking, then that could definitely be their water broken, and we do some more tests on it. Okay, so it's not necessarily a big gush. It could be a leak, and that's based on where the tear is and how big the tear is in the amniotic lining, right? So we want to know how much. Large is also concerning for other reasons. Maybe the baby's head's not well applied and the cord could come down through the cervix, and that's an emergency. If there's a large amount of fluid, then it's either because the mom has too much fluid, and that's other reasons to be concerned about that. Or the baby's presenting part, ideally the head, is not well applied, and that can cause other problems. Okay. Last note on this slide. This is just showing this is paper that's acidic. Nitrazine is the name of the test. Oh, it's right there on the slide. Nitrazine. Amniotic fluid is alkaline, so it will turn the paper blue if it's amniotic fluid, and if it's urine, it won't. It'll stay yellow. Okay, because urine is acidic. So this is just like a simple kind of like layman's test that we can use to kind of push up against her labia and have her cough. And if the fluid stains it blue, then it's very probably amniotic fluid. When you're trying to determine true labor versus false labor, I'm going to skip down to the bottom here because this is the most important part. Whether your cervix is changing is the true sign of labor. Okay. So it can be that it's thinning or that it's dilating, but if there is no change in your cervix, then you're not in labor yet. That's like the kind of the rule. Okay. So contractions can follow like a normal pattern if you're in labor versus not in labor, but some people honestly are contracting pretty regularly. But again, if their cervix isn't changing, and that's usually like, we usually give them like a 2 hours. So 2 hours from one check to the next check. If their cervix hasn't thinned or dilated, then it's not labor yet. Because labor is going to follow a predictable pattern and progression. All right, so going back up here. False labor contractions are generally irregular, and true labor patterns are developing into a regular pattern. In false labor, walking will often ease your contractions, whereas in true labor, if you're walking, it can help speed your labor and make the contractions actually more intense, as it's putting more pressure on the cervix and helping the cervix dilate more. In false labor, no bloody show because there's no changes in the cervix yet. And in true labor, there's bloody show present. I don't love this one. I might take this one out because it says true labor discomfort is in the lower back or abdomen. That's very vague, and also that can happen in false labor or preterm labor or different things too. A lot of times preterm labor, you have that low back aching and you don't even recognize it as contraction. So honestly, I would kind of disregard this for the most part. But it is true that the different types of pain, like most of the time, your pain's gonna, in true labor, your pain's gonna kind of originate in the back and kind of come around toward the low front, as opposed to being somewhere else, like at the top of your uterus, the fundus, or something like that. Okay. All right, and then labor is broken down into 4 stages. The first stage is actually what we normally think of as all of labor being, because the first stage is from 0, like 1 centimeter dilated, all the way to 10 centimeters dilated. So that's the first stage, okay? Labor occurs when you have all these hormone changes, and it's signaling your body to let's get things going. Okay, so you can kind of be aware of this. Progesterone goes down, estrogen and oxytocin and prostaglandins going up. Okay, and then the first stage, which is again what we normally think of as labor, is broken down into 3 phases. The early phase, let me click forward one and see. I can't remember if we talk a little more detail. No, we don't. Okay, so let me go back. The early phase is going 0 to 5 centimeters, basically. There used to be different definitions, like you hit active phase when you hit 4 centimeters, but now active is considered 6 centimeters. So early is that early phase of labor. It can take a long time, maybe even 12 hours to go from 0 to 5 centimeters. And the primary action here is that your cervix usually effaces first. So it starts thinning first before it starts dilating. So that's a lot of what we see in the early phase. And then when you get to the active phase, the dilation starts happening more rapidly and predictably, usually dilating about 1 centimeter an hour until 10 centimeters. But this transition phase, which is usually 8 to 10 centimeters, this is, I feel like, a little confusing there, but the transition phase, your body is really taking over. You're feeling an urge to bear down. You're starting to lose control. This is when people say, I can't do this. I can't do this anymore. They often will feel like they need to vomit. And sometimes in labor and delivery, we say, that's good. You're going to, well, not to the patient, but we talk about how she vomited her baby out because that vomiting motion and that kind of action that your body does is the same bearing down action that happens when you push too. So it's like that's still kind of pushing the baby out. Okay. But let me be clear, this first stage is not pushing, not ideally. This is just when you first start to feel the urge to do that, up and then up until you're 10 centimeters. And then we're pushing during the second stage. Okay. So the first stage is, think contractions and dilation of the cervix. And the second stage is you're already fully dilated and you are pushing. So it's the descent of the baby through the pelvis. And that's considered the latent second stage. When you're already fully dilated, you're not pushing yet, but your contractions are helping push the baby down. This sometimes happens though, like simultaneously or within a couple minutes of each other, right? Some moms will, especially if they have an epidural, will let them labor down, quote unquote, meaning you're already dilated, but you're not really feeling an urge to push yet, and your baby still has a little ways to come down before we have to push. So let's see what your body does. Maybe it can have some latent passive descent before we do the really hard work of pushing. Okay. So again, first stage is 0 to 10 centimeters dilated. Second stage, you're already fully dilated and you're looking at the descent of the baby through the pelvis, passive and or active pushing. Okay, second stage pushing. And then third stage is, we mostly think of the placenta, but it includes the moment of birth and through the delivery of the placenta. Okay. And then the fourth stage is just the recovery time, which is 2 hours after birth. And this is very, very critical time for the transition of especially the baby, as you can imagine, but also the mom for watching for bleeding and other complications. Okay, so postpartum hemorrhage most often will happen within these first 2 hours if it's going to happen, and we're watching really closely, watching her bleeding during this stage. Okay. There are some other good videos and things listed on the resources page that you can hear that a couple times in a couple different ways. Make sure you're referring back to your book, though, when you're looking at the number of centimeters dilated for each specific phase and stage, just to make sure that I didn't say it just a little bit wrong. I don't want to confuse you, so make sure you refer back to your book for that too. Okay. All right, we talked a little bit about engagement before, but engagement is the descent into the pelvis. So what we call the baby, did your baby drop yet? The drop into the pelvis, that's what we're talking about, is the baby engaged. And we kind of say it that way because once it's engaged, it's kind of stuck down there. It's like locked in position. It's engaged. It's not coming back up the other way, probably at that point, okay? This term asynclitic means misaligned. In the South, we sometimes call that cattywampus. This baby is cattywampus, and we mean asynclitic. And what it means is the baby is turned ever so slightly that it's having a hard time coming down and getting fully engaged past like the pubic bone here. This picture does a pretty good job of illustrating why that happens, why it matters. Here, the baby's back is kind of toward the mom's back, and it's having a hard time making that angle. Here, it's kind of hanging low down in the front and having a hard time making that angle too, okay? So here in medical terms, anterior asynclitism, the baby is to anterior. This would be a normal synclitism, and then posterior. Okay. Any questions so far about those things? Okay. As you probably know, oftentimes we need to induce labor for a medical reason. Sometimes moms are requesting an induction of labor, which we will not do until 39 weeks if it's by request, okay? 39 weeks is like the hard and fast cutoff for medical teams. We will not induce you before that just because you ask. It has to be a medical reason, okay? We use a Bishop score to determine how favorable your cervix is to how successful might this induction be, okay? Let me see if there's, no. Oh, and there's another slide on the second stage of labor. So you can find the Bishop score in your book, but it's literally using the cervical exam and a couple other factors to determine, it's like a score for how close you are to delivery almost, how close you are to labor. So this going over that hump of non-labor into labor. If your cervix is already fairly dilated, fairly effaced, the baby is pretty low, so on and so forth, your Bishop score is going to be higher. There's lots of different methods of induction, but here are a few. So cervical ripening is used if the cervix is not, quote, ripe yet, which means it's not very soft, it's not really dilated, nothing's really going on yet, and the cervix needs to be ripened before we start contractions, basically, because if we have contractions and the cervix isn't open at all yet and it's not ready, then it's not really going to do anything to the cervix. So cervical ripening can be a prostaglandin gel, or it can be an insert, which is kind of what this picture is showing. This is called Cervidil. And it kind of looks like a little flat tampon, but it's like a little card containing prostaglandins, which is the hormone that tells your body to go into labor. And you put it up behind the cervix and leave it for 12 hours. And it kind of gradually releases this hormone that tells the mom's body to ripen the cervix. Okay. Cytotec is similar to that idea. I mean, it's a prostaglandin, but it's delivered by a pill. Now, Cytotec can be taken orally, but it's not as effective. So normally we do it vaginally, and it's a tiny pill to start with. And what we give is just a quarter of this teeny tiny pill, and it's enough to tell the mom's body to go into labor or to ripen her cervix. That's given every 4 hours. And then after 12 hours, the doctor would reevaluate and see if we want to switch methods. But interesting thing about Cytotec, you'll notice later that it's also given postpartum and in these like huge doses. Okay, so an induction dose might be 25 micrograms, tiny, whereas a postpartum dose is like 1,000 micrograms. And a lot of times we give that rectally because we need to, and I'll explain that later. But so it just takes a very small amount to tell our body what to do for that point. Other just kind of tidbit of information that might help as a memory tool. Prostaglandins. You have probably heard that one way to put yourself into labor, if you're not in labor yet, is to have sex. Well, it's not just because of like the physical act of sex or even necessarily the orgasm, which that actually orgasms can contain oxytocin, your body produces naturally, which is the other hormone here we're about to talk about that puts you into labor. But it's also the sperm itself. Sperm contains prostaglandins. So the sperm being up near the cervix and being there for a while can tell the body to start ripening the cervix too. Okay, so that's fun fact of the day for you. Why does sex work for inducing labor sometimes? And then back down to oxytocin here. Oxytocin works directly on the uterine muscle to start contractions. We give oxytocin to induce labor if the cervix is already ripe. And your body naturally contains oxytocin anyway, especially you can induce it, like I mentioned, orgasms would do that, but nipple stimulation too can be a natural way to produce oxytocin to try to tell your body to go into labor. It's a very high alert medication. It's very closely titrated and monitored. Because it works directly on contractions, the potential adverse effect, you'll learn when you, again, kind of touch on the fetal monitoring. But if we are contracting too much and too often, it cuts off blood supply, basically, to the placenta and to the baby. So we see it directly in the baby's heart rate and how it's responding. And that's something that we're watching very closely. Okay. Oxytocin is another medication we give postpartum in way bigger doses than we do in an induction. So I just think it's amazing that all the changes that the body's going through, that we need this teeny tiny dose before and after we can have these enormous doses. So let's see if there's anything in this picture to mention. Cervical balloon, also called a Cook's balloon, is a way to manually dilate the cervix. So instead of using hormones, it's like a Foley catheter balloon on either side of the cervix, and you increase it gradually until they're big enough that they're basically pushing the cervix open slowly. Okay, so that can help get labor started up to about 4 centimeters before the balloons fall out. And sometimes that helps get over the hump into active labor. And then this is an Amni hook. It's just a little plastic stick with a tiny hook snag on the end that the provider can snag the edge of the bag of water. They call it snag, let's go snag our bag, they'll say, to go break our water. And the action of breaking water also produces the body's like, oh, the water's broken. Ideally, this is what the body does. The water's broken. We need to start labor because it starts producing all those similar hormones. It just knows, which is also amazing. Okay. This is like the care of the mother during the second stage. Second stage, again, remember, is pushing, primarily pushing. She often will feel the need to bear down spontaneously. She feels like she has to have a bowel movement. That's exactly what it can feel like when the baby's putting pressure down low like that. It can feel like the same feeling, and that's the same way she needs to push. A lot of moms are afraid they're going to poop, and we just say, that's okay. If you do, you probably won't even know it. I won't tell you. But you know, it's common. It happens and it's okay. So, we definitely want her though to do open glottis pushing. You might see this again. I know this has been, you know, something that's come up in the past. I don't know if it'll be on, you know, your tests here with us, but open glottis pushing means don't hold your breath and push. Okay. We'd rather you push and like moan or yell, or at least just breathe out while you're pushing. Because closed glottis pushing can cause her to have to Valsalva down, and you know, she might pass out or drops her blood pressure dramatically. And if that affects the baby's heart rate. I know I've referred to the fetal monitoring lecture a few times. But here I'll refer to it again. Make sure you're picking up on this main theme that the mom's blood pressure greatly affects perfusion to the placenta and the baby's heart rate. Okay, so if anything that causes the mom's blood pressure to drop low is going to affect the baby's heart rate, and that's a problem. We're going to start seeing late decelerations. Okay. Second stage is usually 2 to 4 hours. It depends on if it's her first baby, if it's her 7th baby, if she has an epidural, if she doesn't. We want to encourage position changes, especially upright positions are great. This position that she's in is not the best position. It's a very common position that we see in all the movies, and even in real life, that's common once she has an epidural, but that's not a very good position physiologically for pushing. We'd rather be upright and let gravity help you, and you know, be able to the baby come down instead of horizontally out. Okay. We're gonna still encourage relaxation, especially in between contractions, because we want her to gather her energy. Sometimes she's like freaking out, you know, and we're there to try to help her, you know, focus and realign there. We're gonna, of course, offer comfort measures, and fetal assessment is like, if it's not priority 1, it's priority 2. Okay. We're watching the baby that whole time. And then warm and cold compresses. Warm compresses are shown to help decrease perineal tears. If we put warm compresses on the perineum in between when she's pushing, that can help. And we're just trying to provide a calm, supportive environment and getting ready for delivery. Okay. Yeah, go ahead.
Can you hear me?
Yes.
Okay. Back to the last slide. Do they have women, because I've always heard that them being upright was the best position, but do they have them in this other position? Do you think, is that for safety? Like, they can't catch, it's easier to catch the baby? Like, is that why?
Yeah, it's definitely easier to see and catch the baby. Whether it's technically for safety, I maybe debatable. So yes, I mean, I think if you're taking that angle, it is. If you're taking the angle of whether it's safer though for like a shoulder dystocia, then it's not. It's more dangerous, more likely to have a shoulder dystocia, which again we'll talk about, you know, in future weeks if you're not familiar with that term yet. But it's more dangerous for the baby in this position as far as labor goes, and the shoulder. But it's easier for the provider to see, yes, and easier to quote catch the baby probably when the mom's in this position. So I mean, I think it's more convenient for, you know, the providers, and that's why we see it so much. But it's just not ideal, the most ideal physiologically. But yeah, good question. Okay, episiotomies. You know, the mom may tear, and there's different degrees of tearing. But an episiotomy is an intentional cut into the perineum. It can be median or midline, which is straight down, or it can be mediolateral. I think there might be another slide on lacerations. Let me see. No. Okay. Let me tell you a little bit about these. So lacerations, there's different degrees. A first degree would just be like a little tear in the skin, not very significant or severe. And then a second degree would go down a little farther through like the tissue, the soft tissue of the perineum. A third degree actually goes through the muscle to where you can see the muscle of the rectum, not through the rectal muscle, but where you can actually see it. And then a fourth degree is all the way through even the rectal muscle. So that one is really, really bad, really lots of considerations for cleanliness, right? Keeping the incision, or not the incision, but the wound clean, and repairing that as best as possible and so forth. But so a fourth degree is literally all the way, it's an open hole from the vagina to the rectum. And that's as terrible as it sounds. So you can also have vaginal and urethral lacerations. So urethral would be, of course, up here on the front side toward the urethra. Vaginal and cervical are much more serious as far as bleeding is concerned, because perineal and urethral lacerations we can see, they're more external, right? But vaginal lacerations are along the length of the vagina and we can't see those. And cervical lacerations, same. Both, and especially cervical lacerations, can bleed a lot. And so we would be monitoring this mom for bleeding. And we're like, her fundus is firm, her fundus is firm. I don't know, you know, why she's bleeding. We would suspect a laceration after that. And nurses can't assess that. We can't go internally to look and see what's going on. So we just have to be the ones to recognize it and think through what it might be, and then call the doctor over to ask them to assess it and ask them for help. Okay. So we'll talk about this more when we get into postpartum more, but the most common reason for postpartum hemorrhage is a flaccid uterus. So the uterus is not tight and clamping down on all those blood vessels. So she's bleeding freely. But if her uterus is tight, then the next thing we would look for is trauma. And that would be like the cervical or vaginal lacerations. Okay. Episiotomy is much less commonly used now. It's only usually done if there's a shoulder dystocia happening or there's some other concern. So it's one of the like data things that they track for doctors, and you know, doctors like their stats to look good, so they don't do them as often, which I think is a good thing. You know, we don't want to cut if we don't have to. But all right. Mechanism of birth is like a series of events that happen. I think the next slide goes into a little more detail, but At the birth of the head, the provider will do the Ritgen maneuver where they're putting pressure kind of on the rectal area that can help decrease the likelihood of lacerations. And then the baby's shoulders are born, and then the body and extremities, of course. And then we're taking care of the baby. Let me see. I just want to see how we're doing on time and stuff. I think we're doing okay. We're moving along. So the mechanism of labor here. There are 7 cardinal movements. Some of these, like in here, can happen in any order. Like it doesn't have to be A and then, or it doesn't have to be, yeah, like B and then C and then D. Some of them can happen simultaneously or in a different order. But basically, we already talked about engagement. And then we've got the flexion of the head as it kind of curves around the pubic bone. And then internal rotation. So the baby's head will actually turn to fit through the space. And then again, extension as it goes under the bone. And then restitution and external rotation. So you'll actually see, if you see a delivery, you can see as the baby's head is crowning and then it like actually turns and rotates at the same time. And then expulsion is birth. Okay. So just kind of be familiar with those. Sometimes they'll throw a question in there. It's hard to anticipate what the question will be about, but just try to familiarize yourself with it a little bit and maybe find a video on that. All right, C-sections sometimes are unplanned, and sometimes are scheduled for various reasons, right? But if a mom is a C-section or she is suspected to go to C-section, for instance, if the progress is not going well or the baby is, the heart tones are not reassuring, she's going to need to be NPO. And then we're going to do pre-op labs. We have pre-op medications. We're going to clip her hair and put on SCDs. Who knows what SCDs are? Yeah, go ahead. Keon, I see your hand.
I can't remember what it stands for, but I know it's the machine that kind of wraps around your legs that kind of help prevent blood clots by applying pressure, like intermittently.
Yeah, exactly. Yeah, so it's it stands for sequential compression device, and it's like a little inflatable massage thing for your calves, or sometimes all the way up your leg. But it'll like alternate, and just kind of squeeze your calves and then release it and try to encourage blood flow to prevent blood clots there. So that is another thing that's tracked, and it's like a mandatory thing that we do to help prevent blood clots for our patients. Okay. And of course, we're going to give her education. She needs a Foley catheter too. Most of the time we do that after the spinal is already done, or that if she already has an epidural, they may dose the epidural to get her numb enough for the C-section. So I would say most facilities do the Foley after she's already numb, so she doesn't have to, it's not another thing she has to stress about. And then for our post-op assessment, of course, what is one major thing that's different for a C-section post-op assessment than a vaginal?
Incision care.
Incision care. So we're watching the incision. We're making sure it didn't dehisce, separate. We're making sure that we don't see signs of infection there, and that she doesn't have bleeding from that site. Okay. We are going to talk a lot more about newborns in the future, so I'll just touch on it here. But very first thing we do at delivery is put the baby skin to skin, even before the cord is cut. Skin to skin has a lot of really good benefits. for the baby. So we'll talk more about those later, but just know skin to skin is important. Most places will do delayed cord clamping now, as long as the baby is stable. If the baby's had a severe shoulder dystocia, or there's something obviously already wrong, the baby comes out blue or whatever, they may not put the baby skin to skin. They may go straight to the warmer to give it help that it needs, because keeping it attached to the placenta is not going to help the baby if it was already not getting what it needs from the placenta before delivery, right? Something's wrong, we go ahead and cut it and take it to the warmer. But most of the time, for babies that are doing well at delivery, we'll do delayed cord clamping, at least 1 minute, sometimes 2 minutes. It gives extra blood volume to the baby, pumps. It allows for that transition, right? There's a lot of fast transitions happening right at delivery. The baby's going from not having to breathe to having to breathe. It's using its lungs, and it's got all those valves have to shut, like right away to redirect the blood flow to the lungs and let the oxygen come to the lungs. So all of those things that are happening right there at delivery are pretty amazing. They happen very quickly, and delayed cord clamping gives a little bit of extra transition time, that they're still getting some oxygen from the placenta, so they don't have to rely on their lungs quite so immediately. Okay. We always have at least 2 nurses at the delivery, one primarily focused on mom and one on the baby. And then we get APGAR scores, which again, we'll talk about later more, but APGARs are like that initial set of vital signs and visual signs of how the baby is doing, so that we know how we need to respond. Okay. Oh, here, we're talking more about APGARs right now. Okay, APGAR scoring. We assess at 1 minute and 5 minutes, but if the baby had a score 0 to 6 at any point in the 1 minute or 5 minute mark, then we're going to continue and get it at 10 minutes, 15 minutes, and 20 minutes. Okay, so we'll continue it every 5 minutes up to 20 minutes. By the time 20 minutes has passed, the baby's either already going to the NICU or the baby's already pronounced if it's doing really badly. So 20 minutes gives us enough time to see the trend. Is this baby getting better or getting worse, or what's going on? Okay. So we score it. There's 5 categories, and we give 0, 1, or 2 points for each category. There's a good video too on this if y'all want to kind of go back and watch the videos and the resources. But just as kind of a quick overview, we give a score for the activity. So if this baby came out completely limp and isn't moving at all, then it's going to get 0 points for that category. If it's kind of moving, but it's really not active and looking really good and like an angry baby right after delivery, then it might just get 1 point. Pulse goes by the 100 beats per minute is the kind of rule of thumb there. If it's over 100, it gets 2 points. Less than 100, it gets 1 point. And if it's absent, it gets 0 points. Okay. Grimace is about reflexes. So a lot of times we'll try to elicit this reflex by rubbing the back or flicking the foot, or like, kind of scratching the bottom of the foot to elicit some kind of response from the baby. And if the baby doesn't respond at all, it's completely flaccid, that's 0 points. If there is some flexion, so like it pulls back that extremity in response to you, then that's 1 point. And if it's actively moving, that's 2 points. So really, if it's actively moving, it's already getting 4 points right here between these 2 categories. And then the appearance and color. So this is the one that questions will ask about a lot of times, because most babies at 1 minute and even 5 minutes get 1 point for this category, because the body is pink and the extremities are oftentimes still blue. Does anybody know, if you've taken this class before, you might know this, but what's the term for this? The baby's hands and feet are blue.
Acrocyanosis.
Yeah, thank you. So acrocyanosis is the term here. If the baby has acrocyanosis, it's normal within the first 24 hours because there's still a lot of transitions happening for the baby. So if we assess the baby and we see blue hands and feet, but everything else, all the central areas, the head, chest, and body are pink, then that's acrocyanosis and we can document it as that, and that's okay. But it would get 1 point instead of 2 for that. Most babies are not completely pink right after delivery. And then of course, if the baby is blue or pale, it gets 0 points. All right, and then respirations uses this, similar scale. None is 0 points. If it's weak effort or slow or, irregular is not a very good descriptor because babies breathe irregularly anyway, but they would get 1 point and then 2 points for a vigorous cry. So you can see how, if a baby's only getting 6 points, then it might have like 1s on all of these and a 2 maybe on just like the heart rate or something. It's not doing really great and we need to continue to assess it. And that's why we continue to get some more APGARs for a little while. All right, and then the placenta. Again, like I said, this third stage begins with the birth of the infant and ends with the delivery of the placenta. Usually happens, it can happen anywhere from 5 to 30 minutes. If it's been 30 minutes, then there's something wrong. We have a retained placenta, and a lot of times they have to have it manually removed. Sometimes even have to go back to the OR to get that taken care of. As the length of the third stage increases, the risk of hemorrhage increases because if the placenta didn't separate easily and quickly from the uterus, then there might be retained pieces or just issues with the separation. It's basically like an open wound inside your uterus where the placenta was, and you could have issues the longer that goes on. We use the term expectant management. So it's expectantly and actively managed because we expect there to be possible issues with bleeding. So we want to do what we can to minimize that risk. We do that by administering oxytocin. We talked about how oxytocin we give for induction, but then we give it in much bigger doses postpartum, and that helps contract the uterus down nice and tight. Uterine massage also does this. So we'll be up there massaging the uterus, especially if it's not already firm. If we feel a boggy fundus, we're up there massaging it to try to get it to firm up. During this time, we're going to obtain the cord blood to get the baby's RH status, which is important, both because we need to know the baby's blood type, but also because that will affect whether we need to treat our RH negative moms with RhoGAM, right? We'll talk more about that later. But we can also get blood gases. Okay, so here is a cord. This is a really good looking healthy cord, okay? This is the vein and the arteries. Actually, there's one artery here. The other one you can't see, but we get cord blood gases because the cord blood will tell us at delivery was the baby acidotic at all? Did it have respiratory acidosis going on? Because the perfusion wasn't very good, and that can predict how well the baby does after delivery. So for the long term, right? So let's talk about this. Remember, circulation, oxygenation is different for babies and adults, or not babies, but fetuses that have an umbilical cord attached to the placenta. Go ahead, Ivana.
So like essentially it's like an ABG.
Yeah.
But in the umbilical cord.
Yep.
Okay.
So we're getting ABGs, but we get not just arterial, we're getting an arterial and a venous blood gas from the cord. So it's when we say cord blood gases, usually we're getting both because we need to compare the two. So what I'm just going to click through this because I always confuse myself. When we get umbilical vein cord blood gas, it's going to indicate the placental function. Okay, so how well was the placenta functioning? What was it sending to the baby, right? And then the umbilical artery is going to tell us how the baby was doing. So the arteries are going away from the baby's heart toward the placenta, and that's going to give us the actual acid base status of the baby's metabolism at that moment in time. Okay. So the artery gives us the information that we want, but comparing it to the vein tells us even more what to do with it. We won't have to go into that, but the OB providers can. Yes, go ahead.
Also, just oh, sorry. Just to clarify, the umbilical cord contains 2 arteries and 1 vein, right?
Yes, that's right.
Okay, I just wanted to make sure.
We're gonna name it Ava. Remember? So there's the 1 big fat vein and 2 little arteries. And it looks like a little face if you cut a cross section. 2 little eyes and a mouth. All right, and then recovery, like I said, is 2 hours after birth. We're assessing blood pressure and pulse every 15 minutes. Let's talk about this for a second. If a mom is bleeding heavily, do you think we'll see it in her blood pressure or pulse first?
Blood pressure.
Pulse.
I got, yeah, a couple answers. So the answer is actually we see it in the pulse first. We a lot of times don't identify it until we see it in the blood pressure, but that's actually a late sign of postpartum hemorrhage. We're going to see it in the pulse first because the body's trying to compensate for this loss of blood. It's pumping faster. And then once it can't really keep up like the volume and can't compensate anymore, then we see the drop in blood pressure. So once we see a drop in blood pressure, we should be really concerned because that's like one of the later signs. If we see a mom's heart rate going up during the recovery period, then we need to look closer. Is there some concealed bleeding? Sometimes she's bleeding, but there's a clot blocking the vaginal opening. So we don't see it on the pad until we really massage and get those clots out. And then we see that she's been bleeding, internally, essentially. So yeah, that's an important, both of those are important vital signs to watch, right? But that's the actual course we would see.
I have a question.
Yeah, go ahead.
The book says that immediately after you give birth, the vital signs that change is like an increase in temperature, increase in pulse, and decrease in respirations.
For the mom?
Yes, for mom.
Mhm.
So then at what point do we get concerned about an increase in pulse if that's a normal vital sign change?
Yeah, that's a good question. So we would expect to see some change, but if it's going over 100 beats per minute, then it's something we want to watch really closely. And especially if it continues to trend up in the postpartum period, like it might go up because her circulation has suddenly changed, right? Now we're not pumping blood through the placenta. So things are changing there, but we shouldn't continue to see a trend upward. So there's no like hard line for me to tell you other than that 100 beats per minute to just be aware of it. But, because it's different for every person, right? Even what their baseline is. But yeah, that's a good question and just something to watch over time a little bit more. Again, especially if it continues to go up. And I see your question in there too about the APGARs back here. I think. So this is true. You're definitely going to get APGARs if the baby has, I mean, you're going to get cord gases if the APGAR is less than 5. But some facilities, like my facility, wants blood gases on every baby, actually. So it's just another lab that we definitely want to get if we know the baby is compromised in some way. But sometimes we get it anyway. So it just depends on what the doctor orders. So in recovery, we want the fundus to be firm. I've mentioned that a couple of times, but this term boggy or flaccid, if the uterus is floppy, it's not controlling the bleeding. It's not clamping down on that open wound and basically putting pressure. So it's going to cause bleeding. Let me see if there's a picture in here. No. We're almost done though. Position in relation to the umbilicus. So at or after delivery, we expect the fundus to be right at the umbilicus, basically at the level of U. We would call it fundus is firm at U, for instance. And then every day after that, we would expect it to shrink some by about 1 centimeter, which is like 1 finger breadth below the level of the umbilicus. And if it's going in the opposite direction, then that's not good. We don't want to see that. So that's what this is referring to here. Again, we're going to have more on this. So I guess, anyway, you're going to see stuff about postpartum hemorrhage actually throughout the rest of the course. So this is just kind of a good introduction, but we want her bladder to be empty as possible, or empty it frequently, like every 2 hours. A lot of times we say, go to the bathroom every time your baby needs to eat, because a full bladder can cause a boggy uterus and can cause an increase in bleeding. And then lochia is the term for postpartum bleeding, basically. We expect it to be red for a couple of days, and then it'll turn kind of serosanguinous, and then it'll turn white. This is alba. Again, we'll talk more about that later. And of course, we're going to facilitate breastfeeding. I want to see if this is the end. Yeah, I think the rest are practice questions that you can look at in your PowerPoint on your own to kind of test your knowledge there. And then after that, it's the other things that I've lectured on and recorded for you.